Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld and I am so excited to see you all here today. So what we have to cover today is a pretty meaty topic. It can be challenging, but today, we're going to be covering acid-base imbalances with our ABGs. So we're going to cover metabolic acidosis and metabolic alkalosis. Then we'll switch to respiratory acidosis and respiratory alkalosis and everything that these include. So causes, clinical features, and of course, our nursing interventions. We have a few questions at the end using the Rome trick. So stick around for those NCLEX style questions. It's a great way to challenge all the knowledge that you guys will learn today. A couple of housekeeping things before we get started. Follow us at UWorld Nursing on whatever your favorite social media channel is. This live will be on demand on all of our social channels, so tune back in after we're done. If you have to jump out early, maybe you have to join late, you can always see them posted after we're done on our social media channels. Let us know in the comments who here is planning to take their NCLEX soon, who has recently passed, so we can either wish you good luck or congratulate you. And as always, drop your comments, drop your questions, and your answers to today's questions into the chat. We have the wonderful nurse Jasmine moderating today, so let her know any questions that you have. We always want to hear from you guys. And today's subject matter is pretty challenging, so we'll try and work through it slowly, but any questions you have, please let us know. So with that being said, let's go ahead and get started. So acid-base imbalances, let's start at the beginning. Acid-base imbalances are going to be complications of a condition, not a standalone diagnosis itself. It's not something that just presents on its own without something else happening in the background. These imbalances are typically going to be focused on dysfunction in one or two areas of the body. So when we have metabolic imbalances, it means kidney issues. When we have respiratory imbalances, it means lung problems or problems breathing. We need to understand what our normal ranges are so we can spot what's a number that's out of whack, it's moving in the wrong direction. So let's talk about 3 different serum lab values to get us started. And the first one is going to be pH. I bet you all are familiar with this one, you guys, but pH is going to tell us, is our blood acidic, normal, or alkalotic? A normal pH range, I'm going to ask you guys in the chats, what is a normal pH range? Let me know. And bonus points if you know what pH stands for. So go ahead and let us know in the chat if anyone here can name what a normal pH range is. And right off the bat, Brittany got it, 7.35 to 7.45. You are spot on. Way to go. And it looks like we have a couple more people that answered correctly. Great job, you guys. So this is our normal range. A lower number below 7.35 would mean a state of acidosis, and above 7.45 would mean alkalosis. Next up is CO2. We learned about CO2 a few times on these lives. We covered extensively when we do our COPD session, but a normal range of CO2 is going to be 35 to 45 millimeters Haig. A great way to remember this is just to drop the 7 from that normal pH range to give you 35 to 45. This is my favorite way to remember it. And lastly is bicarb, or HCO3 with the little minus sign is how you'll see this denoted in the acronym form. A normal level for bicarb is between 21 to 28 milliequivalents per liter. High levels of bicarb mean we're going to be alkaline or be more acidotic. High levels of CO2 is acidic, going to make us more in an acidotic state. So the last little bit about these general principles. Acidosis either comes from too much acid or losing too much bicarb. Alkalosis, on the other hand, happens from having too much base or losing too much acid. So with that being said, we know our normal values, we know what puts us into acidosis, alkalosis to prime our lecture today. Now let's move on to the metabolic side. So we're going to pull up the acidosis scale. And if any of you guys know, what are some causes of metabolic acidosis? So acidosis means we have too much acid, not enough bicarb. Can anyone here name a cause of metabolic acidosis? I'll give you a few seconds. Alrighty, those metabolic acidosis causes on tap. Let us know what puts us into a state of metabolic acidosis. Alrighty, see a couple answers coming in here. Alrighty, and it looks like a couple of you are spot on. Brittany, again, way to go. But diarrhea can be a cause here. So let's talk about this. That's the main one I see. I see DKA, way to go. But let's talk about this. Vomiting would not quite be one, and we'll get into that later. Vomiting would be more of a cause of alkalosis. But let's start out with causes of metabolic acidosis. So again, we know metabolic means the kidneys are impacted, and acidosis means we have too much acid or we have lost too much bicarb. So for reasons for having too much acid can be things like too much production, maybe an increase in lactic acid from poor perfusion, carbon monoxide poisoning. Lactic acid also increases in sepsis. We can have the release of ketones can cause this from DKA, which it looks like a couple of you guys named, or simply just taking in too much acid, like with aspirin. When people take too much aspirin, aspirin is acetylsalicylic acid. This can cause us to go into a state of acidosis. We can also see this happen from impaired excretion of acid. It's accumulating and we can't get it off. So this can happen in kidney disease. Remember that our kidneys decide to filter what goes out in the urine and what the body hangs on to in the blood. We just did a CKD, or a chronic kidney disease, live last week. So if you have any more questions on that, that will be a great reference to tune back in on. If the kidneys are not properly working or they get backed up, they're going to have a buildup of waste and electrolytes in our blood, which can be acidic elements that increase our acid and put us into a state of acidosis. Lastly, we can also be put into acidosis by losing too much base. Big example of base is going to be bicarb. So when we think of problems with excretion, it can be things like diarrhea, which a couple of you guys named. Way to go. We're losing that bicarb through excessive diarrhea. That GI tract is hyperactive and we're losing too much base, putting us into a state of metabolic acidosis. Now let's switch scales to the flip side with alkalosis and the alkalosis scale. Now, can anyone name a couple of causes of metabolic alkalosis? So I asked you earlier to name some causes of metabolic acidosis. Now let us know what is a cause of metabolic alkalosis. We're switching gears on the opposite side now. It's kind of the same principles as acidosis, just in reverse. So I see one, Vivian, way to go. Suction, this is a great one. Someone also put vomiting. Great job, you guys. You absolutely nailed that. You don't even need me here. But metabolic alkalosis are the same principles of metabolic acidosis here. We're just going to reverse it. So we know metabolic, again, means the kidneys are impacted. And alkalosis means we either have too much bicarb or we have lost too much acid. So for reasons like too much bicarb can be as simple as excessive ingestion of bicarbonate. This can happen through antacids. Those are pretty much just straight bicarb tablets. So something like Tums pills, too much of these can put us into a state of metabolic alkalosis. Also, when we're losing large amounts of acid. And when we talk about this, think of the stomach as your starting point and everything up from there. So the stomach is full of acid. So if we have excessive vomiting or excessive suctioning, two causes that you guys already named, way to go, anything that pulls that acid out of the stomach, out of the body, is going to cause us to trend more alkaline because we're losing the acid, we're becoming more alkalotic. In the same vein, certain medications like a diuretic or a thiazide can also do this. So these cause us to excrete hydrogen into our urine. We know that hydrogen is a big driver for our pH. After all, pH stands for potential of hydrogen. So when we're losing hydrogen, our pH is getting higher, which means it's more alkalotic on the scale, i.e. it's a cause of alkalosis. No shocker there. Alrighty, so let's jump to our acid-base table. What are our clinical features going to be? So with metabolic acidosis, what are these clients going to look like? Think of the things that may have caused the metabolic acidosis as a great jumping off point. So remember that DKA is a potential cause of metabolic acidosis. We know our DKA clients. What are a couple things that are always associated with this? I know that juicy fruit, sweet breath, as well as Kussmaul respirations, those really deep, really rapid respirations. Clients may also show signs of hyperkalemia, so we can see dysrhythmias and cardiac complications that result from potassium imbalances. A big one for hyperkalemia are going to be those tall peaked T waves, and we also know diarrhea can be a cause of this too, which can be a cause these clients may continue to have diarrhea until we step in pharmacologically. Now, clinical features on the flip side for metabolic alkalosis, there isn't a whole lot to say about this, but it's along the same lines here. We see diarrhea with metabolic acidosis, and we typically see vomiting with metabolic alkalosis. And in general, our client's going to have a sense of malaise. They're really just not going to feel very well. Now, compensation. So we are talking about everything that went wrong. Now let's talk about how the body compensates and kind of rights these issues. So in metabolic acidosis, remember we have a low pH, we're acidotic, and low bicarb. So in response, the lungs are going to jump in to help out their friends, the kidneys, who are struggling right now. So what the lungs do to help out is they're going to increase the rate of breathing. So we have an increased respiratory rate so we can blow off that extra CO2, which we know is acidic. When we blow off that CO2, our pH is going to rise, trend more normal, a little bit higher, and our bicarb will also rise, which will help us trend out of the acidotic states. Now switching gears to metabolic alkalosis, it's going to be the opposite. No shocker there. So when we have a high pH and low acid, as we do in metabolic alkalosis, in response, again, the lungs jump in to help out their friends, the kidneys that are struggling. So they're going to slow down to help the kidneys out. We're going to see a decreased respiratory rate. So we're going to hold on and preserve that CO2, which is going to help to lower our pH. Our bicarb will lower as well, which is going to help us trend down to a more normal range. So quick knowledge check. I know this is really confusing, so I want to make sure that we're understanding through each stage. So will breathing rate go up or go down in metabolic acidosis? Just testing out what you all have learned. So when we have a client in metabolic acidosis, do we expect their breathing to go up or to go down as a compensation mechanism? Alrighty, let us know. Again, it's metabolic acidosis. So keep that in mind. And when we breathe, we are breathing off CO2. So in acidosis, do we want to hold on to CO2? Do we want to get rid of CO2? And big hint here, CO2 is acidic. All right, I see some mixed things, and no worries, this is a really, really tricky topic. But what we're going to see is it's going to increase. Our respiratory rate and metabolic acidosis will increase because, again, we're in a state of acidosis. Carbon dioxide is what we exhale. That's acidic. We're going to increase our respiratory rate to get rid of excess CO2 so we can trend back to a normal pH. So in metabolic acidosis, our lungs compensate by increasing that rate of breathing. Great job, you guys. That was confusing, but you did so well. Alrighty, so nursing intervention. So we talked about everything that can go wrong. Now, what can we as nurses do to help out these clients? So remember, metabolic acidosis or metabolic alkalosis, never the primary diagnosis. It's going on in the background as a result of another condition. It's not a standalone condition. So first things first for our nursing interventions is that we need to treat whatever the underlying cause will be, whether it's diarrhea, vomiting, DKA, sepsis. There are going to be some essential practices that we should know as a nurse as well that we can also do in addition to treating that underlying cause. So in general, we're always going to monitor our ABGs, we're giving IV fluids, and we're monitoring our electrolytes and supplementing if need be. For metabolic acidosis specifically, we need to monitor those lab values closely, see which way we're trending, especially that lactic acid, which is especially important for our sepsis clients. We want to watch and see which way this is trending. We want to replace those fluids and electrolytes as we previously talked about, and we're going to need to give certain medications to treat what's really going on here. So if they have metabolic acidosis because of diarrhea, we're going to need to give an anti-diarrheal like a Lamodal, for instance, since we know that client can lose that bicarb through the GI tract if they're having excess diarrhea. And we can even supplement by giving just straight bicarb or sodium bicarbonate to the client to give them more base, which will take them out of an acidotic state. On the flip side, for metabolic alkalosis, what are we going to be doing as nurses for these clients? So same basic principles, treat the underlying conditions, give and replace fluids and electrolytes, and then we're going to give medications that treat what's really going on here. So if we have metabolic alkalosis because this client is vomiting excessively, no shocker, we'll give something like an antiemetic, a Zofran, a Phenergan. And we also want to stop the use of any diuretics that could be adding to the metabolic alkalosis. So we want our kidneys to start sending that hydrogen back into the blood and not out through our urine to excrete it. Hydrogen is acidic. This is going to make our pH go down and pull us out of metabolic alkalosis. And another thing we want to avoid doing in metabolic alkalosis is any additional suctioning. We want to make sure we turn off suction. We avoid doing it in the future. Again, suctioning is removing some of that acidic stomach acid. Our stomach contents are very acidic, which will make us more alkaline or basic if we're taking off that acid. So we want to stop the suction so we can make sure we're holding on to the acid so our pH can trend down out of alkalosis. That was a lot. That was very confusing, but you guys are doing great. Way to go. Alrighty, so a flow chart. We can pull up this flow chart here just for another great reference for you guys. Again, this is a complicated topic and I always find visual references to be so helpful, but a quick refresher before we move on to the respiratory side. So to sum up the metabolic side, metabolic acidosis means we have a low pH, which happens from too much acid and not enough bicarb or base. So our kidneys first try to compensate, but they're not going to be able to swing it. They call for backup from their friends, the lungs. So our lungs are going to breathe faster to blow off that acidic CO2. And remember, when pH returns to a normal range, that is when we would be considered fully compensated. But we will have a low CO2 sometimes, like a refractory low CO2, from blowing it all off as a compensatory mechanism, which is something that we call secondary respiratory alkalosis. We'll talk a little bit more about compensated and uncompensated at the very end of this lecture. Now the flip side, let's sum up metabolic alkalosis. So here we have a high pH. We're at the high end of the spectrum, which happens from low hydrogen or low acid and high bicarb. So our kidneys first try to do it all on their own. When they can't quite swing it, they call for backup from their friends, the lungs. The lungs step in and they start to breathe slower to retain and hold on to that acidic carbon dioxide. We know that's an acid. This will help us to trend downward, move our pH by holding on to the acid. When the pH does return to a normal range, being 7.35 to 7.45, this is when we would be considered fully compensated. But many times as a compensatory mechanism, we end up with high CO2 afterwards because our body tries so hard to retain it to pull us out of alkalosis. This is something called secondary respiratory acidosis. So that's kind of confusing. But again, sometimes when we try and compensate for something, we compensate too much and it puts us into the opposite side of the spectrum. Alrighty, so that sums up the metabolic side of today's lecture. Now let's flip the script and move on to the respiratory side. So now we're thinking about the lungs. We talked about the respiratory drive a lot in our COPD live lecture. If you have any more questions about that, that would be a really great reference to pull up. But quick refresher here, we breathe in oxygen, hopefully no shocker there. This oxygen makes its way through our upper and lower respiratory system where gas exchange eventually happens in the alveoli within our lungs. So our blood will offload CO2 and pick up that fresh oxygen at the alveoli. This CO2 is really where the imbalance all starts to happen in our blood. So in respiratory acidosis, when we are hypoventilating or breathing really slowly, we're going to have a buildup of CO2 in the blood, which will make us more acidic, which we know lowers our pH. On the other hand, in respiratory alkalosis, we're hyperventilating. We're breathing too fast. Maybe we're having a panic attack. We're going to blow off all that CO2 because we're breathing so quickly. We're breathing it off too quickly, which raises our pH because we know that CO2 is an acid, and this is the core of respiratory alkalosis. So quick refresher here, the client is hypoventilating. I want you guys to think about respiratory acidosis. And if the client is hyperventilating, I want you to think about respiratory alkalosis. So hypo with respiratory acidosis, hyper with respiratory alkalosis. All right, so what are some causes of respiratory acidosis? Drop them in the chat if you know them, but let's talk about some causes for, again, respiratory acidosis. So we're starting on the low pH side here. We really just need to tie this into all of our known causes of hypoventilation. So let's start with some more acute causes. First, our client can have an airway obstruction. So think along the lines of choking. Maybe the client is aspirating on some food or a liquid. Next, let's think about our chemical respiratory depression causes. So this can be caused by an opioid overdose, maybe alcohol intoxication, or even magnesium toxicity can repress the respiratory drive. Last is going to be respiratory muscle weakness. So something we can tie this to, if you've ever heard of it, is Guillain-Barré syndrome, or a spinal cord injury can also cause this. Remember that the part of our brain that controls our breathing is in the brainstem. So injury to that cervical spine area can really impact breathing significantly by affecting the breathing control centers of the brain. Now, those were our acute causes. On the chronic side, common causes, I think some people named this already. I see it here. Anjali Patel totally got it. Way to go. So COPD, big one here. And that's, of course, chronic obstructive pulmonary. So we know it's a chronic cause. We talked about how our clients with COPD, their respiratory drive is triggered by oxygen instead of CO2, which happens in a normal, healthy client without COPD. So essentially their body becomes so accustomed to these raising levels of CO2 that it blunts the body's respiratory response. Alrighty, on the flip side, respiratory alkalosis, let's move to our high pH side. What are some causes of this? So remember that with respiratory alkalosis, we're going to be hyperventilating. So breathing too fast, breathing off that acid, which puts us into an alkalotic state. Some common causes of hyperventilation can be panic attack, anxiety attack, any pulmonary conditions like a pneumonia can cause this, an asthma attack, a pulmonary embolism, or a PE. All of these things are going to cause impaired gas exchange from obstruction in the airway or the lungs. Other common causes can be things like fever, really high altitude, or a client that's on a mechanical ventilator and the ventilator is set to improper settings, causing them to hyperventilate, excuse me. Alrighty, so clinical features, respiratory acidosis. So what are these clients going to look like? Beyond their decreased respirations, because we know they're hypoventilating, these clients will start to show neurological signs. So we can have manifestations of high CO2 and that low oxygen or hypoxia, so essentially not getting enough oxygen to the brain. How this looks in the clinical environment is we can see these clients present with confusion, lethargy, drowsiness, headache. As this progresses, later signs can include seizures and even coma. So some really serious complications here. On the flip side, for respiratory alkalosis, we again have that low CO2 and a fast respiratory rate. So we're hyperventilating. Clients can see things like lightheadedness, dizziness, confusion, and tachycardia as a result from this. And due to the other processes happening in the background, our client may also have hypocalcemia. So we might see those associated findings with low calcium, which include tetany, numbness, and tingling, especially around the mouth, can be a really common sign of hypocalcemia. So same with respiratory acidosis, late findings for respiratory alkalosis are going to be seizure and coma. So we need to know how to identify these things and treat the client early before they progress to these more serious complications. All right, so we talked about all of those scary complications and manifestations on the respiratory side. Now, what can we as nurses do to help these clients? So just how our lungs stepped in to compensate for our kidneys in metabolic acidosis and alkalosis, now our kidneys are going to return the favor. They're going to help compensate for our lungs in respiratory acidosis and respiratory alkalosis. So in respiratory acidosis, we know we're too acidic, no shocker there, from the buildup of CO2. Our kidneys jump in to save the day by secreting hydrogen in the urine. We know hydrogen is an acid. This will help get rid of that excess acid, raise our pH back up to a normal range. And our kidneys are going to reabsorb and send back bicarb to the bloodstream, which is a base to help also raise our pH. Now, in respiratory alkalosis, we know we have low levels of that acidic CO2, so we need to increase the amount of acid in our system to lower the body's pH. So our kidneys again step in to save the day. They're going to reabsorb acidic hydrogen and send acidic hydrogen back into the blood to raise our acid. The kidneys will also reduce the amount of bicarb they're producing to lower the base, which in turn, these two things together help to bring our pH back down to a normal 7.35 to 7.45 level. Alrighty, so quick knowledge check. Let's see how you all do on this one. So will hydrogen concentration go up or go down in respiratory alkalosis? So are we going to see our hydrogen concentration increase or decrease in respiratory alkalosis? Drop your answers in the chat. All right, I see a couple answers coming in. Are we up or down, increase, decrease, however you guys want to phrase it, totally fine. And again, I see we're kind of split. No worries, this is a challenging topic. Hydrogen concentration. Hydrogen is acidic, and respiratory alkalosis, they're in an alkalotic state, meaning they're having a lack of acid. They don't have enough acid. So we're going to increase. We want more acid to offset the base. So in respiratory alkalosis, we're going to see a compensatory mechanism of that hydrogen concentration increasing to bump up the amount of acid and pull us out of alkalosis. That was tricky. We want to make sure we're bringing us down, but someone phrased it really well. My print said the more hydrogen, the lower the pH. So true, because hydrogen is an acid. It's acidic. Alrighty, great job, you guys. So increase was the correct option. That was tricky, but let's keep going. And I think this will really start to hit home when we go over our Rome trick at the end. So let's talk about nursing interventions for the respiratory side. So remember, these ABG imbalances are never going to be the primary diagnosis, but rather they're a symptom of another condition. So obviously, first and foremost, we always want to treat whatever that underlying cause is, but there are some additional essential practices that we should be implementing as nurses. So monitor the ABGs, see which way we're trending. We're going to give supplementary IV fluids. We're going to replace electrolytes as needed. For respiratory acidosis, we're going to need to work on improving our airway and breathing. Remember, these clients are hypoventilating. They're not breathing rapidly enough. So we can help to raise the head of the bed. We can suction if the client is having any secretions. We're going to apply some supplemental oxygen to really help perfuse. And we're going to give medications that treat the condition. So if this hypoventilation was caused by an opioid overdose, we may give a Narcan. If it's caused by alcohol intoxication, we're going to treat that. But we also need to be ready to intubate the client if the hypoventilation reaches a certain extent. Now, on the flip side, for respiratory alkalosis, we also need to work on improving our airway and breathing, but it looks like the opposite of acidosis. So here in respiratory alkalosis, we're hyperventilating, we're breathing too fast. We may need to apply supplemental oxygen and medications. We may give something like a benzo or benzodiazepine if the client is hyperventilating because they're having a panic attack or an anxiety attack. We want to encourage them to take slow, deep breaths, and we want to maintain a calm atmosphere to help decrease their rate of breathing. Alrighty, so we're going to jump back to that flow charts. And again, we're quickly going to do a little summary of the respiratory side before we move on to the Rome trick and, of course, our corresponding questions. So respiratory acidosis, to sum everything up, is low pH. This happens from hypoventilating and too much CO2. We're not blowing off CO2, we're holding on to it, and it makes us acidotic. Our kidneys step in to compensate, but kidneys work a lot more slowly, so it can be kind of delayed. Our kidneys are going to increase the elimination of hydrogen, which is acidic, to help raise the pH in our blood, bringing us to a more normal range. They're also going to help to retain bicarb, that base, to help to raise our pH. But again, it happens really slowly. The kidneys don't work that fast. We may need to offer additional support like airway and breathing support, maybe even push some sodium bicarb in the way just to help those kidneys out, because it does take a little bit longer for them to compensate. Now, on the flip side, in respiratory alkalosis, here we have a high pH. We're on the alkalotic side. This happens from hyperventilating, low CO2, because we're blowing it all off as we have that really fast rate of breathing. Now, our kidneys compensate, but again, they do it slowly. They don't work very fast. Our kidneys will compensate by holding on to the hydrogen in the urine, which is an acid. They're also going to lower the amount of bicarb they're producing. These two things in tandem work to lower our pH and bring us down out of an alkalotic state. Again, these things happen slowly, so as nurses, we need to make sure we're acting fast. If the client is awake, we need to encourage them to breathe slower, maintain a calm atmosphere. If they're having this from improper ventilator settings, we need to make sure we get a respiratory therapist in there, we decrease the ventilator settings, and we stop them from hyperventilating. Alrighty, so let's move on to our Rome image. And if any of you guys are struggling right now, I really think that Rome helps to bring everything together. It's like that final step for that light bulb to go off in your head. So let's pull that up. Alrighty, so Rome stands for respiratory opposite, metabolic equal. So it sounds pretty obvious. So what we're essentially going to do is, so respiratory opposite means our pH and our CO2 are going to be trending in different directions, meaning if our pH is high, our CO2 is going to be low. If our pH is low, our CO2 is going to be high. It's an opposite or an inverse relationship. Metabolic equal means that it's going to be a metabolic issue if our pH and our bicarb are trending in the same direction. So if our pH is high and our bicarb is high, we know it's a metabolic issue. If our pH is low and that bicarb is low, we know it's also going to be a metabolic issue. It just makes you look at which way things are trending. If they're in opposite directions, we can bet it's going to be respiratory. If it's in an equal direction, we can bet it's going to be metabolic. Now, how we figure out how something is compensated or uncompensated is actually pretty simple. So if the pH is still abnormal, the body hasn't fully been able to compensate. It hasn't been able to return that pH to a normal range. So when we see an abnormal pH, but a normal CO2 or bicarb, that means we're not fully compensated. We haven't been able to fully get there. We know it's compensated if we've seen that pH return back to normal. That would be considered compensated, but one of our two values, carbon dioxide or bicarb, is still going to be out of whack. They kind of like sacrificed themselves. They kicked in high gear to make sure we could return the body's pH back to normal. So again, respiratory opposite, metabolic equal. If we see an abnormal pH, but one of our CO2 bicarbs are still are normal, this would be uncompensated. But if our pH is back to normal and we have an abnormal carbon dioxide or bicarb still, this means it has been compensated for. Alrighty, so with that being said, let's try out our first question. And I know this is challenging, so let's walk through this one together. And then we have 3 questions today. I'll kind of let you guys do it on your own for questions 2 and 3. Alrighty, so question number 1. Here our pH is 7.28. Now I like to do this by the arrow method. I know that everyone kind of has different things they do, but I always taught the arrows. So for our 7.28, our pH normal range is 7.35 to 7.45. So where is that 7.28? That's low, right? So I'm going to draw a downward arrow here. Now for our carbon dioxide, our CO2, our normal range is 35 to 45 millimeters Hague. We're at 55, so that's high, right? I'm going to draw an arrow going upwards. Now where is that bicarb? We're sitting pretty. We're 23, which is in between our 21 to 28 normal range. This is still a normal bicarb. So right off the bat, we can tell that we're in acidosis because our pH is low. That part was pretty easy. But are we respiratory opposite, or are we metabolic equal? Well, our bicarb was normal, but our pH is decreasing while our carbon dioxide is increasing. This is opposite, so we can know it's respiratory. So far we have respiratory acidosis. Now in this case, is it compensated or is it uncompensated? For this one, this is kind of an extra step, but that pH is abnormal, meaning it would be still uncompensated. So our full answer here is uncompensated respiratory acidosis. Alrighty, and most of you guys got that. Way to go. Okay, question number 2. Let's go ahead and pull that one up. I'm going to give you guys a few seconds to do this one on your own before I step in. Test out your knowledge. I know you're going to do great. All right, but we have 7.48 is our pH. We have a CO2 of 30 and a bicarb of 24. So what is this client in? All right, moving on to question 2. I'll give you a few seconds. Draw those arrows. No worries if it takes you a little bit. All right, I see some great answers coming in. So right off the bat, the pH is high. So what does a high pH mean? It means we're in alkalosis. That part we can check off. Next, let's look at our CO2. So that's 30. Our normal range is 35 to 45. So we know 30 is low. So right off the bat, pH was increasing, but our carbon dioxide was decreasing, meaning they're trending in opposite directions. Respiratory opposite. Off the bat, we know this is respiratory alkalosis, which I believe is option number 4. Now, last step, is it compensated or is it uncompensated? Well, has that pH been able to return back to a normal range yet? No, so we're still uncompensated. So in this case, we're in uncompensated respiratory alkalosis. And I see a lot of you guys got that. Way to go. I told you now is where it all comes together. Alrighty, last question. Alrighty, question number 3. So here the pH is 7.37. Okay, things are getting trickier. That's still technically in the normal range. Our CO2 is 33 and our bicarb is 20. So what is this client in? Let us know. Alrighty, this one's a tricky. It's kind of the final one to send you off. Is that definitely a challenge? All right, so question number 3, we have a 7.37 pH, which again, that's in a normal range, 7.35 to 7.45. So hint, hint there, that kind of lets you know whether it's compensated or uncompensated. All righty, keep those answers coming. I'll give you a few more seconds. I know this is challenging, especially if you're new to it. So I want to make sure everyone gets a chance to kind of formulate their own answer. Alrighty. Give you a few more seconds. I see lots of right answers though, so you guys are doing great. Alrighty. Looks like Matt Uris got it right. Way to go, you guys. Okay, so that pH is within a normal range. This is a big hint that the body has compensated. We have compensated for whatever is going on. It's 7.37, which is still in normal range, but it's towards the lower end, which also gives us a hint. So it's normal, but in parentheses by it, we can also put a down arrow because we know it's on the lower end of normal. Now, if that's going down, where is our CO2? Our CO2 is also slightly low at 33, but that bicarb is going to be 20, which is low. Bicarb normally is 21 to 28. And good news, if I haven't said this, the new NCLEX does provide you with reference ranges, so you don't need to memorize them all. But we know in this case that's respiratory opposite, metabolic equal, where respiratory would be opposites, and CO2 and pH are trending towards the same direction, so that doesn't fit the bill, whereas metabolic is equal. Our pH is on the lower end of normal. We can put our little down arrow in a parenthesis, and we see the bicarb is low. They're both trending downwards, metabolic equal. We know this is compensated. We already figured that part out. Now we've identified that it's metabolic, and because we're on the lower end of that pH, we can assume it's going to be acidosis. So we have compensated metabolic acidosis. That one was tricky, but you guys did so well, and we know it's compensated. That's really tricky, but because that pH returned to normal, but that's a great question. So because we see that pH has been able to return and kind of rebound to a normal range, that's how we know that the body has compensated for this. Alrighty. Great job, you guys. That was so challenging. I really recommend that you guys look at whenever we post later today, the full recorded version of this. If there's any part that you didn't quite get, you want to go back and clarify something, that's really a great reference for you all to use. Let's take a quick look into our QBank slide. For everyone that already purchased the UWorld product, or for anyone considering purchasing, here's how you get more questions that are tailored to exactly what we learned today. This is just one of the many ways you can filter the UWorld questions. We can filter by subjects and systems and NCLEX topics, and there's so many ways for you to filter it down to exactly what you want to be tested on, exactly what you want to be working on and improving. So here's a little click of that. Go ahead, and if you want to screenshot it, that would be a great chance to do that. And in closing, thank you so much for joining. Today's subject matter was tricky, but you all did so well with it. I am proud of you. Way to go. So join us tomorrow again at 11 a.m. and 7 p.m. Central Time for question drills with myself in the morning and Nurse Andrew at night. Thank you so much for joining, and I will see you all soon. Bye.